ONG, Obstetric and Gynecology Hospital Keningau, dengan tajuk beliau Delayed Cord Clamping in Newborns at Hospital Keningau.
Assalamualaikum and good morning to our hospital director, Dr. Ridwan bin Hashim, respected head of departments, panel of judges, participants and doctors, and to all members of Hospital Keningau. My name is Siti Asma Zakaria, a representative from ONG department. Today I will be presenting on our audit on clinical audit on delayed cord clamping in Keningau Hospital. For an overview, delayed umbilical cord clamping is defined as intentional postponement of cord clamping for at least 30 seconds up to 3 minutes or until cessations of pulsation. The practice facilitates placenta fetal transfusion, providing up to 30% additional blood volume to the neonates. This practice shows benefits in terms of improving hemoglobin, ferritin and iron status during infancy while showing no increase in postpartum hemorrhage risk. Particularly in preterm infants, DCC improves hemodynamic stability and lowers intraventricular hemorrhage rate. And most of international guidelines, which include WHO, RCOG and SOG, recommends DCC for all vigorous newborn, irrespective of delivery modes, whether it's vaginal or cesarean sections, unless there is contraindicated by maternal or neonatal conditions. So previously, DCC has been practiced in all over the world. The reports on DCC on newborn as early as 1984 has been generated, and latest guideline from international is done 2 years ago. So, previously, before we start this audit this year, DCC has been practiced in our ONG department since 2014. However, this practice before this not standardized in Malaysia because not all KKM hospital done DDC previously. Previously, why DDC is not implemented systematically and uniformly? This is because of inability of KKM standard operating procedure, because they only provide practice based on level for evidence, which is referenced by Caucasian orientations, and also there is no clinical percentage or data in correlations of practice of DCC and also risk of DCC in newborn. So starting January this year, our Ministry of Health has issued an instructions for delayed cord clamping or DCC to be implemented systematically and uniformly across all MOH hospitals. So, in accordance to MOH criteria, this year our hospital has audit on DCC. So our main objective for this audit is to determine compliance with DCC at Keningau Hospital in accordance with MOH criteria, and we want to see what is the causes for deviation from this standard. For audit interim, this audit, the process of audit was briefed by our head of department to the doctors and also midwifery team using standard operation procedure provided by KKM, and the data collection strategies were monitored and collected by assigned specialists or medical officer and also sister in maternity labor room suites. So for this audit, we have ensured that all documentations of delivery time must include hours, minutes and seconds, and DCC must be done within 60 seconds starting from completion of second stage. And then data were routinely updated during department meeting, audit meeting. So what is the standard for this audit? Following MOH Malaysia audit criteria, we want to achieve 90% of live birth should receive DCC. So prior of implementing this audit, we have ensured our medical practitioner involved in delivery to be educated and also guide based on KKM guideline and checklist regarding how to do DCC, regardless of delivery mode, whether it includes vaginal delivery or cesarean delivery. So our methods of audit, our audit is a retrospective, descriptive audit of all live birth from February until July this year, conducted using labor room delivery registry and also obstetric records. So the numerator for this audit is number of babies who underwent delayed cord clamping at least 60 seconds after delivery, irrespective of mode delivery, vaginal or cesarean sections. And the denominator for this audit is the total number of live birth. So what we can see from our audit, among 1,846 live birth from February to July this year, 1,737 of them received DCC, making the overall compliance of 94.1% in this audit. The result from our audit surpasses the 90% benchmark set by MOH and is comparable to other national and international reports. And from the audit, we observe no adverse maternal or fetal outcomes. From the audit, we see there are few main reasons of early cord clamping in ONG department. They are divided into fetal and maternal cause. So, in terms of fetal, the reason for immediate cord clamping include low abgas score, fetal compromise, including fetal distress or fetal bradycardia, and also meconium stand liqua. In terms of maternal, the cause of immediate delay cord clamping include maternal instability, as in postpartum hemorrhage, and also acute pulmonary embolism. Acute pulmonary edema. So this graph depicting the number of DCC versus immediate cord clamping in all live birth starting from February to July this year. We can see that DCC was done way much higher as compared to immediate cord clamping every month starting from February. And this graph showing to us the distribution of immediate cord clamping from February to 2025. So we can conclude that the reason for immediate cord clamping, or why the delayed cord clamping not done during delivery, is because of low abgas score, maternal factor, or also fetal compromise. So how to sustain delayed cord clamping strategies in Hospital Keningau? We know that poor ABGA and fetal compromise are the main reasons for DDC were not done during delivery. And the DDC are done by medical practitioner who was in the delivery room. So they are the one who assess the baby whether they're suitable for delayed or need to be done immediate cord clamping. So, in order the assessment is correct, we must ensure that our medical practitioner has continuous NRP training, and this is correlates with yearly or monthly training done with pediatric teams. And for this audit, we audit the delivery book monthly to ensure authenticity of data collections. So, why we do this audit? What we want to see in the future? So, from delayed cord clamping, we want to see good quality of the documentations in terms of cord clamping, whether it's immediate or immediate or delayed, and the reason why it is being done. And in the future, we want to expand our coverage of DCC, including preterm delivery. Therefore, we need ongoing staff enforcement to sustain and further improve adherence. From our audit, we can conclude that ONG Department of Keningau Hospital achieved and maintained high compliance for 94.1% with delayed clamping practices exceeding national standard. And the practice of DCC implementation is consistent with evidence-based recommendations and contributes positively to neonatal outcomes. So this is my reference. That's all from me.